So with this lecture, we're going to begin to discuss heart failure. So with heart failure, there are numerous causes and precipitating factors such as an acute MI, coronary artery disease, hypertension, fluid retention, valvular abnormalities, or arrhythmias, and so on that cause heart failure. So the compensatory mechanisms of neurohormonal activation actually cause the symptoms of heart failure. And we discussed that in the last lecture with the RAS, the sympathetic nervous system, as well as ADH. So this results in inadequate cardiac output to meet metabolic needs. So a decreased cardiac output results in inadequate periphery tissue perfusion. Therefore, you have myocardial hypertrophy, dilatation and remodeling, and pulmonary and systemic congestion. With pulmonary edema, this is a severe life-threatening accumulation of fluid in the alveoli and interstitial spaces of the lung that can result from severe heart failure. So with acute or chronic cardiopulmonary conditions, you see the list below. Pulmonary hypertension, that's a type of high blood pressure that affects the arteries in your lungs and the right side of your heart. So that could be due to left-sided heart failure. It could be due to a PE. Other things, sleep apnea can affect that as well. So heart failure is characterized by ventricular dysfunction, reduced exercise tolerance. Patients might say they're not able to climb stairs, as well diminished quality of life, ask about activities of daily living, and the patient has a short overall life expectancy. So with left-sided heart failure, there's various types of names here. So systolic, that is the old name. You have HFrEF. So that stands for heart failure reduced ejection fraction. And the patient has an impaired ventricular contractile function. So a left ventricular ejection fraction of less than 40%. So the normal range for left ventricular ejection fraction is from 55 to 70. Heart failure patients are best managed by cardiologists. So some of the reasons for the left-sided heart failure, MI, cardiomyopathy, we'll discuss that later in the lecture. So if the ejection fraction is more than 40%, it's also known as diastolic failure, which was the old name. Now heart failure with preserved ejection fraction. It stands for HFpEF. So this is 50% of all heart failures. I'm not going to read through this slide here. Forms of heart failure: right-sided heart failure. The right ventricle fails. It results in inadequate right ventricle output and systemic venous congestion or peripheral edema. So when the right ventricle fails, blood moves to the right atrium and then out into the inferior and superior vena cava and back to the body. So the patient can have jugular venous distension. Normal JVD is 4 centimeters or less. This patient also can have an enlarged spleen, enlarged liver, And so that can cause anorexia, nausea, vomiting, and abdominal pain. And again, the lower extremity edema. And of course, the extremities can be very cold to touch. So with the pathophysiology, I'm not going to read through that. You guys have all my notes. We talked about the activation of the RAS. Just to remind you that renin is secreted by the kidney. Neurohormonal compensation. So with a low cardiac output, that causes a decrease in cerebral perfusion. ADH, that's also known as vasopressin, is secreted from the hypothalamus. So the nerve cells transport the hormone down their nerve fibers to the pituitary gland, where the hormone is released in the bloodstream. As you see all the causes there, endothelin, that is a potent vasoconstrictor stimulated by ADH. Pro-inflammatory cytokines, this promotes systemic inflammation. An example of a pro-inflammatory cytokine is tumor necrosis factor, TNF. That's released by the cardiac myocytes in response to cardiac injury, which causes hypertrophy, contractile dysfunction, and death of the myocytes, and so on. I'm going to skip over the next slide. For health promotion, I wanted to mention that the patient should restrict or abstain from alcohol, smoking cessation if they are a smoker. Also, you want to educate the patient on weight loss. Typically restrict the sodium to 2 to 3 grams per day. Fluid restriction as well, 1.5 to 2 liters per day. That can help some patients. So clinical findings, you need to know these. So with left-sided heart failure, the left ventricle fails to pump. So the patient has feelings of tachypnea, orthopnea, PND, that is paroxysmal nocturnal tachypnea. And this is a person who has PND will suddenly awaken from a deep sleep with severe tachypnea, shortness of breath, and will find him or herself gasping for air. They may be coughing and feeling compelled to get out of bed and assume an upright position. And of course, when the patient, this makes the patient very scared. You just need to reassure them that this is a side effect of the heart failure and try to remain calm. A displaced PMI. A normal PMI is located in the fifth intercostal space at the midclavicular line. In patients with decreased systolic function, the PMI is often laterally displaced. The patient often has an S3. Cough, shortness of breath by basilar crackles. So when you see left-sided heart failure, think of L for lung. So you're going to be having those symptoms related to the lung. Again, cough, shortness of breath, crackles. The patient can have frothy sputum. So this is fluid and even maybe a little bit of blood, and that can leak into the alveoli and out of it. Also organ failure, a low urine output. So our clinical findings in right-sided heart failure. And often results from left-sided heart failure, or cor pulmonale. Cor pulmonale is right ventricular enlargement, secondary to a lung disorder that causes pulmonary artery hypertension, or the right ventricle fails, as well as COPD, ARDS, the alveoli fill with excess fluid. This can be the result of any kind of injury or illness in the lung. And it can be caused from pneumonia or sepsis. So when you look at those symptoms, think about the blood backing up. Like I mentioned in the superior vena cava, right? That's going to go upwards. So you would expect to see jugular venous distension. And then always think below the heart. Hepatomegaly, splenomegaly, peripheral edema. And of course, with the bloating of the abdominal organs, this makes the patient nauseous as well. And also you want to think about weight gain in your patients. So some laboratory findings, BNP, so BNP is released due to ventricular stretch. And this is the most useful to the nurse in determining whether a patient admitted with acute or shortness of breath has heart failure. And it gives you the parameters that you see there. Just keep in mind the beta natriuretic peptide is excreted by the kidneys. So let's say, for instance, you have someone who has chronic kidney failure, somebody who's on dialysis. Obviously, with chronic kidney failure, they're not going to be able to excrete all of that from the kidney. So it can be an abnormally high level. So just be aware of that. Hemodynamic monitoring, you're going to be learning more about this in 422. So diagnostic test, I had mentioned the echocardiogram, the left ventricular ejection fraction, again normal 55 to 70%, and right ventricular ejection fraction 45 to 60. The chest x-ray, you can look for vascular congestion. The heart size can be enlarged, so the patient may have cardiomegaly. They could have effusions, interstitial, as well as alveolar edema. You may see curly B lines, and that's a thin linear pulmonary opacity caused by fluid. An EKG, cardiac enzymes, as well as electrolytes, ABGs. You want to be looking at those as well. So some nursing management, obviously you would want to keep this patient in a high Fowler's position to decrease venous return, and that increases the thoracic capacity. Think about, obviously you're going to be checking the patient's pulse ox, they need supplemental oxygen, and EKG. Dietary restrictions, low sodium, low fat, low cholesterol. Provide the client with a list of potassium-rich foods. If they're on loop diuretics, that can cause hypokalemia. Loop diuretics, that's like Lasix, furosemide, bumetadine or Bumex. Except for your potassium-sparing diuretics or potassium-retaining. Potassium-retaining diuretics are your ACE and ARB. Fluid restriction, spread the fluid out through the day. The patient maybe can have like so much for breakfast, lunch, dinner, and so much later before bedtime. Any patient who has heart failure should be doing daily weights and keeping track of those. Heart failure, it can be classified into symptoms. Frequently, you'll see the New York Heart Association. It has 4 classes. Patients fluctuate in between these classes. So you see here with the classes, class 2 is the most common. So with class 1, there is no limitation of physical activity. Class 2, the patient is beginning to have a slight limitation with physical activity. Class 3, that's marked limitation of physical activity. These patients are comfortable at rest, but less than ordinary physical activity results in undue breathlessness, fatigue, or palpitations. With class 4, these patients are unable to carry on any physical activity without discomfort. I'm going to skip over the ACC-AHA. You can look through those. And this just gives the stage and the treatment as well. So, collaborative management, chronic heart failure. I just want to point out a weight gain of 3 pounds over 2 days, or a 3 to 5 pound weight gain over a week. This needs to be reported to the healthcare provider, and you need to educate your patient to keep track of their daily weight. If they have a scale, I always tell patients, keep a sheet of paper, date. Always make sure they're weighing themselves same time. So I think if you get up, as soon as you get up in the morning, that patient should weigh themselves. And they shouldn't have any additional clothing on. They're in their pajamas, Make sure they're not wearing, maybe they get on heavier clothes because that's going to affect the weight. So with the medications, the ACE inhibitors, the suffix is pril. So angiotensin receptor blockers, those are Artan. An example of that would be losartan. Side effects, I mentioned that dry, hacky cough. If that occurs with the ACE inhibitor, the patient is switched to the ARB. And remember, your ACE and ARBs are what cause hyperkalemia. So patients who are on this typically should get a BMP, at least when initially starting these, probably in about 2 weeks, so the healthcare provider can check the potassium level. Beta blockers, these end in OLOL. So where it says it counteracts deleterious effects of the SNS, it inhibits renin and norepinephrine release. These are contraindicated in patients with heart failure, asthma. Always educate your patient to check their pulse. If the pulse is less than 60, they need to contact their healthcare provider. If patients on beta blockers as well, these need to be weaned very slowly because this can precipitate severe rebound hypertension. And again, so your side effects could be a bronchospasm or bronchoconstriction, fatigue. Remember, they blunt hypoglycemia effects. Other medications, aldosterone antagonists. This would be your spironolactone or aldactone. And you want to avoid combining these with potassium-sparing diuretics because aldosterone, this can cause hyperkalemia. So obviously you wouldn't want to take aldosterone with an ACE or an ARB, right? Other things that it can cause is gynecomastia. It causes GI upset, such as vomiting, diarrhea, stomach cramps. Bildel, that's another drug that is often used. I'm going to let you read through that as well as the next slide with Entresto. So with diuretics, they decrease the preload. The loop diuretics, I mentioned furosemide or bumetadine. So if a patient has, a lot of times you may have a patient in the hospital and they go into heart failure. So, things that you want to assess your patient for, you want to listen to their lung sounds, what's their oxygen level. If the patient has crackles, typically the doctor will order Lasix. And, the action, it inhibits the sodium potassium chloride pump of the kidney in the loop of Henle. So side effects of Lasix are hypokalemia, potassium of less than 3.5, and you have to remember that a low potassium can potentiate DIG toxicity if that patient is on digoxin. A low potassium increases the risk of arrhythmias. It can cause hyponatremia. So if the patient is experiencing a low potassium level, you would want to hold the diuretic, restrict water intake, and replace potassium loss. Thiazide, hydrochlorothiazide, caution in these patients if they're allergic to sulfa allergies. So an example of sulfa would be Bactrim that we discussed last semester. So with thiazides, they have a favorable effect for patients who have osteopenia and osteoporosis because thiazides, they slow down bone demineralization. Side effects of these could be hyperglycemia, hyperuricemia, especially if that patient has gout. They do cause hypokalemia as well as hyponatremia. So again, you're going to be monitoring a BMP to look at that potassium level. And patients typically if a patient is put on Lasix, typically the healthcare provider will automatically put them on 10 to 20 milliequivalents of potassium daily. And then again, they recheck a BMP 2 weeks later. So with digoxin, this is a weak positive ionotrope. Remember to take the pulse prior. Typically it's held if the pulse is less than 60. Educate your patients to take at the same time each day. Report signs of DIG toxicity such as confusion, muscle weakness, anorexia. Typically they may see halos. Typically a normal digoxin level is 0.8 to 2.0. It may vary with different books. Also remember to check your potassium level as well. Nitroglycerin, we've discussed this. I'm not going to go over that again. With nitroprusside, nipride, this is also given for a hypertensive crisis. It's a potent vasodilator. It's given IV. It reduces pulmonary congestion. It improves the myocardial contraction. Side effects of this, obviously you would think about hypotension, headache as well. This needs to be protected from light. I'm going to skip over the next drug. You guys can read through that on your own. So I'm going to skip over a couple slides here and read about sudden cardiac death. So I'm moving to what is an ICD therapy. So an ICD therapy, it consists of pacing, cardioversion, defibrillation therapies to treat brady or tachyarrhythmias. So you have an external program that's used to monitor the access, the device, parameters, and therapies for each patient. So with CRT or biventricular pacing, a CRT device sends a small electrical impulses to both lower chambers of the heart in order to help them beat together in a more synchronized pattern. So this can improve the heart's ability to pump blood and oxygen to your body. And you can read through your indications that are stated. And then of course the next page, it just shows you a photo where it has the leads right and left. I'm not going to go in too much about that because we talk about that in 422. So let's see here. I'm going to discuss pulmonary edema, and then I'll have to cut this video and start another one. So I mentioned pulmonary edema. It's a life-threatening event that can result from cardiogenic factors such as acute decompensated heart failure and pulmonary edema. In pulmonary edema, the left ventricle fails to eject sufficient blood, and pressure increases in the lungs because of accumulated blood. So I'm going to stop this video here, and I will start up again with part 2.